Thank you, Chairpersons. Greetings to everyone. So this is my study, comparison of efficacy of OCCIs versus conventional single clear corneal incision in reduction of total astigmatism. No financial disclosures. Approximately one-third of patients undergoing cataract surgery are eligible for the treatment of pre-existing astigmatism, and not correcting this astigmatic component during cataract surgery will fail to achieve spectacle independence. This is possible using manipulation of the corneal incision parameters, not only the size, location, and shape, but also the number. There is an enhancement of an additive flattening effect of two opposite clear corneal incisions compared to one incision, and previous studies have documented this with a 2.8 to 3.2 millimeter keratome. However, modern phacoemulsification surgeries with 2.2 millimeter incisions, this effect is yet to be quantified. So the aim of this study was to compare the efficacy of adding an OCCI on the steep meridian versus performing surgery on the steep meridian alone during 2.2 millimeter phacoemulsification in reducing pre-existing corneal astigmatism. This was a retrospective clinical study including 34 patients with senile cataract who underwent clear corneal phaco with PCIOL, monofocal non-toric PCIOL. So this was the eligibility criteria as follows. All cases with disorders which could modify corneal astigmatism were excluded. After thorough pre-op examination, including BCVA, UCVA, refraction, slit lamp biomicroscopy, fundoscopy, tonometry, and keratometry, the measurement of total corneal astigmatism was done using the telecentric keratometry of the IOL Master 700, and all surgeries were performed by a single experienced surgeon without intra-op or pre-op limbal marking using the approximate limbal landmarks as seen on the slit lamp examination. Patients were divided into two groups. Those with astigmatism less than 1 diopter were in group 1 and had single incisions on the steep axis. Those with astigmatism greater than 1 diopter had OCCIs made after IOL implantation with a visco-filled anterior chamber. Post-op follow-up at 1 week, 1 month, and 3 months was done with total keratometry, and the results were statistically analyzed using t-test, and p-value of less than 0.05 was taken significant. Of the 34 eyes fitting inclusion criteria, 17 were allocated to each group. The groups were comparable at the baseline in demographic parameters, and there were no statistically significant differences. This is the table and the chart. The baseline astigmatism in the two groups was significantly different. Both groups achieved statistically significant correction of the total corneal astigmatism at the end of 1 month. The net change of astigmatism achieved at the end of 1 month for group 2 was approximately double as compared to that of the group 1. This is also shown in this chart. At the end of the third month, we had a significant attrition of the number of patients. However, the results were comparable with the findings at 1 month, with approximately double correction of astigmatism achieved with two opposite corneal incisions and mean correction of 0.62 diopters. Astigmatism is a major cause of suboptimal vision after cataract surgery. Other existing modalities for treatment of corneal astigmatism have their own disadvantages. A steep meridian corneal incision for phaco is recommended to reduce astigmatism, but a single incision is insufficient if astigmatism is beyond 1.2 diopters. OCCIs are self-sealing, pose no additional risk, require no surgical equipment extra, and are effective in reducing astigmatism. How effective? Previous studies have shown that variable correction of astigmatism is possible with 2.8 millimeter or 3.2 millimeter OCCIs, but this effect is not yet documented for 2.2 millimeter opposite clear corneal incisions. In our study, a 2.2 millimeter keratome was used, which explains the smaller change observed compared to previous studies. We observed that this has encouraging results in correcting mean astigmatism by 0.57 diopter, even in the short term of 1 month of follow-up. However, a final mean correction of 0.62 diopters was achieved at the end of 3 months, which may imply that a fair stabilization of astigmatism is achieved by 0.57 month, 0.57 diopters, even at the end of first month with opposite clear corneal incisions also. The study has limitations of retrospective design, small sample size, and loss to follow-up. Long-term outcomes and larger sample size may be necessary to establish the quantum of effect that this 2.2 millimeter OCCIs may have in correcting the corneal astigmatism. To conclude, OCCIs are reliable, easy, and cost-effective for management of mild to moderate pre-existing astigmatism, and the enhanced effect over the single clear corneal incisions is demonstrated by this study. These are my references. Thank you.
Just one question. You are doing the surgery from the superior limbal or temporal limbal?
Sir, the steep axis was determined by the keratometer, and the main incision was placed at the steep axis, at approximately the steep axis, as was determined by the limbal landmark on the primary slit lamp examination. So it can be superior, it can be superior-temporal, it can be sharply temporal, might be slightly inferotemporal also, up to say 20 degrees or so, might
So
be supernasal also.
definitely. And another point, it means it was variable in your study,
Yes, sir.
not site specific, on axis incision.
On-axis incision
And
as
the other
defined by the
point,
biometry.
what you did with the OCCI, how you just made an incision or you did some maneuvers through
No,
OCCI?
just made an incision and then sealed it in the routine process.
Okay. So it's
Have you noticed the oblique incision opposite to steep is better or just opposite to that steep axis that is better?
On axis steep incision, on the steep axis, if the incision is placed, then it produces flattening and correction of the
Suppose
pre-existing
steep is
astigmatism.
0, 180 degrees, so where should be your incision?
0 180 degree. So my primary incision will be placed at 180 degree temporal, whatever is whatever is whichever point of that line falls temporal, and my opposite clear corneal incisions will be about 180 degrees away. So that would be sharply nasal.
so definitely the previous study, just to point it out, that's whenever you are making an OCCI incision, it is then working, it's creating some influence when you are doing some maneuvers like IA at the end or like that.
Yes, yes.
Number one. And the other point is that whenever you are doing OCCI, especially in a superior segment has a different effect on the astigmatism.
Yes.
Temporal segment has a different aspect on the astigmatism. So we cannot generalize all those things. Definitely we can compare it, but and 2.2 millimeter incision as documented in the previous studies are very less astigmatism inducing. That's
Exactly.
why that's a microincisional or
Exactly.
you
So,
can
so the objective of this study was, say, we do not use a larger keratome. We do no maneuvers through the OCCI per se. We don't use a preoperative or intraoperative limbal marking system. This is just as simple as it can get. And let us see how much is the effect that we can achieve. So a 0.6 diopters of correction is quite a fair effect for someone, say, coming up with 1.4 diopters. He gets a 0.8 at the end of the 3-month period. So this is the quantum of effect that we could document with this small study. And definitely, probably larger studies with comparison of the superior and temporal subgroups would probably give more insights into this kind of a picture that we have got.
and also the this because its follow-up was for a very short period. So even in OCCI it was said the results are suboptimal over a period over a larger period of.
Exactly,
So
exactly,
you
sir.
need to have a larger
So
follow-up period.
that is one part of one limitation of the study which has been acknowledged. But the practical aspect of this is that cataract surgery patients usually do not follow up for a very long time until the cataract of the other eye is very significant, or maybe they have some other ailment, say glaucoma or something that they come to you with. So this is something that the follow up is quite difficult to achieve practically.
Thank you, Dr.